Hi, I'm Dr. Jack Krauser. I'm a periodontist from Florida, and I'm at the American Academy of Implant Dentistry in New Orleans. This is actually my third presentation for Dental XP, and if you find it informative, you can go back into the archives and see some of the other work that we've presented with this exciting group, Dental XP. Initially, I'd like to cover a couple of terms. The term Nobel Guide is a template that is used for patients created using the Nobel Procera software. Teeth in an hour is a term created from Nobel Biocare, which indicates a guided surgery done with a surgical template and a final prosthesis delivered at the time of the placement of the implants. The final prosthesis is created using Procera technology in the CAD/CAM laboratories of Nobel Biocare to get us to the final restoration. Teeth in a day is a different concept. That's where we would perform a guided surgery procedure and place a provisional restoration. Patient would wear that for several months, and conventional techniques could be used to complete the case. Guided surgery is a generic term that's used to describe the use of a surgical guide or template to place implants in a three-dimensional way based on some computer-based planning. Immediate function is the ability to place an implant with a crown or bridge restoration attached where it is in occlusal function. Immediate loading is the ability to put an implant into a site and actually put the functional load on the implant itself. Immediate restoration is slightly different. In an immediate restoration, we would place an implant after an extraction socket, but put the restoration out of occlusion, so it's an immediate restoration, not necessarily in function. Immediate placement is where we would take a tooth out and place an implant into that particular socket. Totally different than a healed ridge where we would place an implant. I give you these definitions so as I'm delivering my presentation, you'll have a better idea of where we're coming from. Some of the cases that we'll look at, we have totally edentulous arches, partially edentulous treatments, single and aesthetic zone cases. When we're planning these single aesthetic zone cases or the partially edentulous cases, we have to consider the vital anatomy of the sinus and the nerve in particular, because that's critical in our planning of lengths and diameters for the implants. Another concept is that the guides that we use are either called templates, guides, or surgical guides. We prefer not to use the term stent, which is something that's used in vascular medicine to prop up an artery or a vessel, and a stint is something where people would go to Las Vegas for a 3-day stint to deliver their show, like Frank Sinatra and his Rat Pack. This is a virtual example of a guide. You see a guide in position in the light blue. You see a mandibular case. The mental foramen is observable, and a series of implants are positioned both in the best available bone as well as in ideal prosthetic situations. As a periodontist, I'm excited about using these in surgical cases, but it also gives my restorative teammates ideal positioning for their restorative performance. Here's a patient that presents. On the x-ray you see he had totally edentulous arch with severe atrophy. His history included the loss of a subperiosteal implant approximately 13 years before. He's been wearing the upper denture, totally uncomfortable, and my prosthetic teammate asked me, can you perform maybe 2 implants to help stabilize this gentleman's denture? So we set him up to initiate the perhaps teeth in an hour, teeth in a guide, or guided surgery procedure. Dr. Clive Bonner was my teammate in this case for the prosthetic phase. The clinical views show definite severe atrophy both in a horizontal and vertical dimension. We started planning the case, and these are some images from the Nobel Procera software. And you might recall I was asked, can I do 2 implants for this gentleman? You see on the screens, we're actually able to position 6 implants, and by rotating the software around, we get a 3-dimensional view to see how the implants indeed are positioned properly, do not bump into each other, and the rings on the bottom are the actual guide rings that will be embedded into the surgical template that will guide our implant into these positions. It's critical that these rings do not touch or bump into each other. When you're actually using the planning software, if the rings are too close or implants are touching each other, the site will turn red as a default, and you'll know to move the implant out of the site. You could also look at the implants in position. Here are 6 implants. These anchoring pins will help stabilize the guide in position, and again, nothing is touching each other. This particular radiographic image is perhaps one of the most important for this case presentation. In red, we see the implant well positioned within the triangle of bone that presents for this patient. The buccal plate is evident. The sinus area is superior to the apex of the implant, and we see the palatal bone in white. You also can see, in a more coronal manner, the superimposition of the prosthesis. Now, I'm feeling good at this point that the implant is actually going to be embedded in quality bone. Then I look at the restorative need of the patient, and we can see that the implant will indeed emerge on the palatal aspect and in the cingulum area of that radiographic prosthesis. So we have a well-positioned implant both from the bone perspective or surgical perspective and for the restorative perspective as well. Here are some other images from that particular case, and in the upper right slide we see that 6 implants were positioned. This is the intaglio, or the inner surface of the virtual denture that we will use for the patient, and you see the implants are emerging in nice positions, both surgically and prosthetically. Again, another view showing the palatal aspect of the emergence. That information is then transferred within the software to create a milled or virtual guide. This guide is made in a stereolithographic methodology with resins being laid down, and the rings correspond to the diameters of the final size of the implant. Using the Nobel system, there are rings that will correspond to Nobel Active, Nobel Replace, the Nobel Brannemark system, all slightly different in size, and there's instrumentation kits that will follow. In the upper right, you see the receptors for the anchoring pins that will help stabilize the guide in an ideal position. In the upper left, we see the implants being positioned right through the guide rings. The middle shows a panoramic view taken immediately postoperatively, and we see 6 implants in a 2-dimensional panoramic view. No big deal there, but I'll get to the cross-sectional views in a moment. The slide on the upper right shows how minimally invasive and relatively atraumatic this technique actually is. Now, if I was thinking about where the implants would be before I opened up a flap, I don't think they would come out in this particular position. But this was done in a flapless approach where the best available bone was based on the software and the cone beam data that was incorporated into the site. These are the post-operative ICAT confirmations. We have one of these devices in our practice, and it enables us to actually check the accuracy of the planning to what we actually got for the patient. And you can see in these images, we do in fact have the implants well within the triangle of the bone, within the best confines of the buccal plate, apical aspect right below the sinus, and on the palatal wall as well. At 2 weeks, we have a very minor amount of inflammation. The patient is quite comfortable. He went back to his denture that had a soft liner at this stage, which was different than the device we used to actually take the radiographic scans for his case initially. As I mentioned initially, we were asked to do a denture retention concept for this patient. We were able to fabricate a bar on top of the 6 implants, and Dr. Bonner performed a nice bar retained denture. You see the patient's upper lip aesthetics. He's quite happy. The case went on for several years, and here are some postoperative views. A little bit later in the treatment, the lower jaw of the same patient was starting to break down, old endodontics, a large post you see in position tooth number 23, and we decided to consider implant therapy for the patient. He asked us, can we in fact do a guided surgery? So we set up the planning of the 3-dimensional software using his mandible and we were doing the same exact steps. Here you see the implants in position. The larger than normal opening here was due to the fact that we needed to have our radiographic guide fit over his existing dentition. That does not preclude us from allowing the implants to position in a guided manner. This case received an immediate functional load, 5 implants in the mandible, and this is the provisional restoration that was performed approximately 2 months after the implants were in use, or installed, excuse me. Here's the case as we're evaluating for the final restoration, and he ended up with a full ceramic restoration on the implants, supported by the maxillary bar and a new upper denture. His case is about 4.5 years old at this point in time. Quite happy patient, and we were able to perform this restoration. I do some part-time teaching at Nova Southeastern Dental School. This is one of our famous patients that got implant reconstruction, and unfortunately you could see that that implant is covered by a very, very thin soft tissue biotype. You could see the whole surface of the implant. What was wrong in this case? Could be many things, but certainly the position of the implant too far to the buccal plate is probably one of the problems. Now, if you look down at the restoration, you see that this is a strategic implant abutment for this patient, so you could see the catastrophic nature of a malpositioned implant for a particular patient type like this. In using our cone beam data, you should get to know the different views that you could see, which are helpful for planning. On the upper left, you see the axial views, which is like a loaf of bread and the various slices. The coronal view takes the head in a cross-sectional view. Sagittal looks at it in a longitudinal manner. And then the slicing, which I use very often and we use in the planning steps, give us a similar to a coronal view, but in just one jaw at a time. And these are the views that we like to use for the patient. I mentioned earlier the so-called triangle of bone. This was taught and known to us by Scott Gans back in the early 1990s. Some of us kind of thought about it, didn't really appreciate it. And when we started looking at patients in 3 dimensions, we really saw how it applied to our treatment planning and in our objectives of positioning an implant in an ideal position. The slide on the left shows a natural tooth, and you see that the labial plate of bone is extremely thin. Many of our cases actually do have paper-thin labial plates of bone, much less than we actually think, and certainly much less than the graphics that we might see at an implant company's booth showing a particular implanted position. The middle slide shows a guided case where the implant was positioned very nicely within the confines of the bone. The slide on the right is a case that I performed maybe 10, 15 years ago, and now that we have the iCat in our practice, we're able to do some post-operative views, and you see at the most apical aspect on the facial plate there was a very, very slight perforation. This was not symptomatic for the patient, but it just taught us that we do have these considerations even on successful cases. But it went on, it was not a problem for the patient. So we have this cute little cat. Nobel is working partnership with Imaging Sciences to include their software in the purchase of an iCat cone beam device. These are the images that we would see initially on the iCat. Shows the various views, including the lower left, which is a virtual 3-dimensional model. And we do most of our planning in the cross-sectional views in the lower middle. So I believe these slides are tremendously important. You see the little red dots. These are giving me measurements of actual width of the bone at various levels. We can plan these cases. Do they need a ridgeplasty? Do they need bone in a horizontal manner? Do they need bone in a vertical manner? And you see the superimposed prosthesis, which is also tremendous information. As a surgeon, I want my restorative colleagues to give us ideal restorations, and they want me to put their implants in ideal prosthetic zones. So we could tell right off the bat if we're going to need angle correction abutments, customized abutments, or we can use the typical straight abutments that are available from the companies. So we would position an implant into place, and we could tweak it, tilt it, torque it, and maneuver it in the best available bone as well as the prosthesis. So when we do our guided surgery, there are 8 critical steps. Patient evaluation is no different than any complex evaluation that we do for our typical implant cases. The radiographic guide is a duplication of their prosthesis, a removable prosthesis, or their existing denture prosthesis without any metal, and it fits into the edentulous zone. It will have radiographic markers. We like to have maybe 6 to 10 markers positioned not in a linear way, but staggered around the radiographic prosthesis. The patient will wear that during the taking of the initial scan. That particular prosthesis is then removed from the patient's mouth, and a second scan, or known as the double scan method, is done of the prosthesis in the same plane, in the same orientation that the patient was wearing it. So if you have a lying down technique, you'll have to position the surgical radiographic guide in a lying down fashion. If the patient was sitting, you put it just as they were sitting. Then the information is put onto a disc or sent through the internet or a thumb drive key, and the surgical or the colleague doing the plan can load it into the software. The software is loaded and starting the review process to plan the implants as you ideally choose. At this step, you can save it at any moment in time. You could send it to your teammates. We oftentimes work with laboratories that are interested in what their aspect of the case will be, so we can download through the internet, send them an actual plan of the case, do some adjustments, and when we're finally ready to go, we have an approval step. We click, we save and approve the plan. It then gets put into the CAD design version of the software, where you see a virtual guide created. If you approve that, that gets sent off through the internet as well. You have an order manager that will order the exact parts necessary. If you have an implant inventory, you may choose to not order the implants for that particular case. If you're going to do a teeth in an hour case where you want final restorations, you have an opportunity to order parts for the laboratory technician, including an exact duplicate or an exact duplicate denture for that particular patient. And you have these choices in the order manager. In the newer versions of the software, you have order status. You could actually log on, check your various orders that are in the internet, and the orders are coming back now at about 3 days. So it's almost immediately. It leaves our practice, comes back in a few days. When we do cases with teeth in an hour, the surgical template is sent to our laboratory partner. They bring it up onto their software to see exactly what we're going to deliver in the surgical aspect, and they start creating a master cast from the DICOM or the computer information. They create the actual physical master cast, and from that, they could then scan the tops of where the implants will emerge after I place them, and in advance, create a ProSera framework. These were originally done in a milled block of titanium, and now they're being done in titanium, chrome cobalt, as well as various zirconia. We are able to get a full arch in zirconia using this methodology. In North America, the facility is in Mahwah, New Jersey, which is in the suburbs of New York. They're always welcome to show you the facility. There are also facilities, I believe, in Japan, and the original facility is in Europe to do these ProSera steps. That information is allowing the restorations to be made. All this gets sent back to the surgical colleague, and the team meets in either office, and the case is then delivered to the patient. The so-called teeth in an hour case does actually take about 1 hour or less to deliver without any muss or fuss. The patient is anesthetized, the surgical template is positioned, we let them sit for about 10 minutes without even starting to allow any of the volume of the anesthesia to settle throughout the tissues. The patient is wearing a hard putty bite to uniformly seat the surgical template in the mouth. When we're ready to begin, we'll introduce the anchoring pins. We take out the putty matrix. We perform our implant surgery through the surgical guides, take off the guide, and our teammate sits down and places the restoration. If you're doing the case totally yourself, you'll have the different phases to work with. When we use the Nobel system, all of their kits are set up in a way that makes sense logically, from sizing to the torquing tools that are necessary for the restoration.